Welcome everyone. Today we're gonna talk about the elbow, some elbow problems. I wanna personally thank Harvard Global Orthopaedic Collaboration and Dr. Kiran Argawal for the kind invitation. Elbow is my patient, and I hope with this presentation I'm gonna give you some hints, tips, tricks on how to deal with some technical points on how to do open arthrolysis and rehabilitation. I'm Paolo Arrigoni. I work in Milan, Italy, and elbow practice is my main activity. So whenever, if you need some form of make a pause. Let's go back. My name is Paolo Arrigoni. I work in Milano, Italy. Elbow is probably 70% of my practice, so it's one of the main aspects of what I'm doing. And if you're interested and you want to communicate with me, please feel free to contact me. And of course, I'm going to be more than happy to help you if I can. I have some conflicts, and those are my conflicts. And when we talk about elbow stiffness, we are talking about different animals, we'll say, different scenarios. One scenario is about degenerative osteoarthritic elbows versus post-traumatic elbows in which we have a neurogenic contracture. Those are different because, of course, in the first case, people come for pain. In the second scenario, they come for stiffness. Even if they show up with similar imaging and similar needs, these are completely different situations, and we have to know that. Normally, the very first scenario can be alterated with some swelling, edema, and in another situation is to have a late or a cold elbow. That is completely another story. Another situation that can be also absolutely different is to have heterotopic ossification versus malunion versus scar formation. And those are different situations. So when we're talking about stiff elbow, we have to deal with all these kind of situations. Another point is the relation with the ulnar nerve and the neurogenic contraction that can be connected with it, because of course, the position of the ulnar nerve with respect to the elbow is quite unique in the body. We have in the posterior medial sector of the elbow, we have skin, then the ulnar nerve, and then the joint. So the nerve is very connected with the joint. And also, we have also to remember that the nerve has to glide from 0 to 130, 135 degrees of flexion. So we ask this nerve to follow the joint in a quite important range of motion excursion. Another point we have to deal with is understanding if the stiffness or the reason of stiffness is more intra or extra-articular. So I'm going to go through these points, mainly how to deal with conservative treatment, how to plan on imaging the job we can do and we are going to do into our operative room. And then we're going to go on understanding the surgery on columns, ulnar nerve management, and how to obtain flexion, extension, and rotations. And also understanding the stiff and destabilized, if you want to call it like that, or sad elbow. And my personal approach to post-op treatment. Conservative approach plays a role. We just have to pass from an anatomy-based model, so we treat what we see basically on imaging, toward a more another way of thinking of the elbow that is more related to the position of fault of the joint. Maltracking of the joint, thinking that sometimes the neurophysiological model, so the way in which our brain thinks to how to use the elbow is different from what reality is on imaging. Sometimes we have very bad elbows in terms of imaging that work or flex and extend much better. And sometimes we have the opposite. So understanding that sometimes hyper or hyperalgesia is different from what we can expect from that. And that's why sometimes we have CRPS, also complex regional pain syndrome around the elbow. So treating an elbow is a teamwork. In which there is a team, pain team, psychologist, occupational therapist, or sometimes a single person can be all of these figures, but you have to deal with understanding the needs of the patient to try to help the patient. The ulnar nerve always plays a role because it can be a cause or the effect. We never know if it's more the cause of the effect. But what we know is that in a situation of stiff elbow, if we can gain range of motion in a rehab context, so in a conservative measure, it's always the way to go. Because of course, if improvements go on without surgery, those improvements are slowly gained and very likely they are not going to be lost. Conversely, whatever we gain in terms of range of motion with whatever we do inside the operative room is destined to be redimensioned later on because of the possibility of the muscle to follow the range of motion we gained under anesthesia. So we always have to deal with these two situations. So whenever we can gain motion in a conservative way, let's go on in this way. So what we can do is to ask our PT to work with the accessory movement that are normally secondary to physiological movement that is primary. Sometimes like a joint with a, let's say a loose body inside of the joint, or a minimal scenario in which that joint have to reposition more medial, more lateral, and with side movement we can understand what's the best way to let that elbow to move. So we use this medial lateral gliding with the strap. And again, it's a teamwork. We have to talk with our patient and the physical therapist. So if there is, in terms of improvement, there is an improvement, we go on. If there is not an improvement, we can modify some parameters, direction of the glide, intensity, force, repetitions, overpressure, managing and controlling pain, and we can go in that direction, trying to improve. If there is absolutely no improvement, then we can rethink to that patient, that elbow, stopping what we're doing and reconsidering the best strategy to act. Study published in 2021 in which patients exhibit significant depression and anxiety symptoms if they were exposed to post-traumatic elbow stiffness. So just to say that a lot of times we tend to focalize on a mechanical problem of a stiff elbow, but there are a lot of associated aspects to be treated and managed. So that's why it's a teamwork also in this sense. Splinting plays a bit of a role in the stiffness of the elbow. This is a systematic review of 232 patients published. These authors are, the majority of these authors are from the Netherlands. Denise Egendal and Michel van de Beckerom are very good friends. And they showed that both dynamic and static progressive splinting bring to good results. And we can go on up to 12 months if we obtain range of motion. So again, this is normally something we don't do in other countries, but I mean, in countries with limited resources, instead of going to the OR very early, we can try to progress with static or dynamic splinting. And sometimes these splints can be done in a very easy way with the very easy materials. Another way of approaching the situation, another way to approach this situation is with this dynamics way of splinting. So those are devices that the patient can utilize by themselves, and there are no significant differences between the flexion arc of motion and extension arc of motion if we push them to use by themselves. There is also an advantage of the patient pushing his elbow by basically with an auto treatment. That is, the patient is controlling the pain better than anyone else because it's not an external force. So patient is going to stay always in the correct range of pain without bypassing the level of pain that can be detrimental for that elbow. There are also some other options, modern options. One is using the in this randomized placebo-controlled study, based in the distal, supracondylar, or intra-articular humerus fracture. They were tested DASH, VAS score, and range of motion after 3 months between using Botox associated with this condition, and both botulinum toxin type 1 injection prevent post-traumatic pain and elbow stiffness. So it's a very interesting study. I personally never used this, but this can be also a device can be associated to our treatment. How to plan some bony work we can do instead into the operating room. First of all, we can understand through dedicated CT scans in maximum extension and maximum flexion what's the theoretical endpoint, bony endpoint that this elbow can have. And this is a good point that we can think about. On the other side, on CT, what we do is to understand if there is a maintenance of the joint line, because of course everything is theoretical, but we can give motion to that elbow if there is a possibility to glide, and if there is some theoretical cartilage preserved inside of the joint. If the joint line is closed, then there is no way we can really think to improve range of motion performing some definitive releases. And on the other side, we can understand if there are points of contacts that we can sort of work on by bony limited resection that can give us more space and giving us removal of impingement situations, so gaining space for that elbow. Reading and planning CT scans, also sliding as a video, spinning the elbow can help us to understand what can be the final result. So I suggest you to use the CT scan as a sequencer, like or a video. Of course, also we can understand the cam effect. Sometimes we have a path extension of the elbow. That elbow reaches the final range of motion in extension, but this is the same inflection. And at a certain point, with the action of the extensors, the triceps first of all, the joint line tend to be opened, and in this way we can gain more extension. But it's a pathologic extension. And we can think that maybe resecting some bone, we can give that elbow a more physiologic way of extending and gliding. And then we can resect some bony spurs, as we can say, and we can also measure them, thinking that for a 5.2 millimeters bone resection, we can have a gain of some degrees in extension. This is something we can also, keeping an eye on being objective in our measurements can be a very good point in understanding our results and to be critical with our results in the post-op. This is the way in which I set up normally my room. I work almost all my elbows in a lateral decubitus position. This gives me a lot of access. Normally, I do I perform normally a single posterior incision, unless recent elbows in which I moved to do 2 separate incisions on the 2 columns, medial and lateral. But if you are in a learning phase, doing a single posterior incision, I think is the way to go. It's easier and give us a broad exposure to all the aspects of the elbow. And then we have the thinking columns. When we work on a stiff elbow, there is just one thing we don't want to land into. That is a stiff and unstable elbow, or because of the release we have performed to destabilize that elbow. So we have to keep in mind very nicely ligament insertions. And ligament insertions, both on the medial and lateral side, have not to be released unless we have a plan on that. But let's stay in the releases that do not damage and do not put the elbow at risk of instability. So there is an anterior column and a posterior column, both on the lateral and the medial side. Here we are looking at the lateral side of the elbow in this model, and if you see the LUCL is the band of the LCL that connects humerus to the forearm. That have not to be injured. So I prefer to stay anterior and posterior, as those 2 red lines indicate. That's why we start normally posteriorly. we elevate the posterolateral triceps together with the anconeus. Let's remember that the anconeus in this way of thinking is the fourth head of the triceps. It's not an independent muscle. So we say posteriorly first. We want to develop the space that stays posterior from the humerus, dorsal side of the humerus, and in between the humerus and the triceps, and then going down posteriorly. In this way, we land it to the cochlear interval, where theoretically, if we stay higher, if we stop this release higher than the radial head, we have no risk of detaching the LCL from the supinator crease on the ulna. So go first to find your space in between the humerus and the triceps posteriorly at the level of the humerus, and then run down up to the level of the radial head. Don't go further down or more distant. This is what we do. We clean our space up to the point we see to the joint, and then we pass to the medial side. Medial side, again, we have an anterior column and the posterior column we don't want to develop. And this is something we want to do, preserving anterior band of the medial collateral ligament. That is the most important area where we want to work on. Normally, the way in which we can extend our window in which we can see inside of the elbow is flexing the elbow. If we flex the elbow, we detend the anterior structures, and apart from posteromedial, where the ulnar nerve is, anterolateral and anteromedial, we detend. We have the brachialis pushing away the median nerve and arteries, and in this way we gain space. So going proximal and going in flexion, following the humerus, the humeral columns, and flexing the elbow is a way to protect our structures. So ulnar nerve management is a point. Normally, there are two great ways to manage ulnar nerve in terms of stiffness. One is to release the nerve and to leave the nerve in situ, and the second one is to transpose the nerve. Normally, a severe contracture is normally correlated with a nerve, ulnar nerve that doesn't glide. A. And B, a severe contraction, in particular inflection, needs a posterior band of the MCL release. These two things obligate the surgeon in the majority of situations to mobilize the nerve. Because of course, if I want to arrive to the posterior band of the MCL, I have to cut the band and I have to mobilize the nerve. And normally this goes with a ulnar nerve transposition. Of course, this is completely different if we have a minor contracture or a degenerative elbow. But in severe contracture, normally the nerve has to be transposed. So this is the way in which we normally obtain flexion, and is with exposing the posterior band. The posterior band of the MCL normally is represented by the basement or the floor where the nerve lies normally. So we cut through that fibers, but if you see with this preparation, the nerve has already been mobilized medially and protected and highlighted with a Penrose. So this is the cut we want to do to obtain flexion, as you see here in this small video. So we want to go and expose the posterior band of the MCL. Anteriorly, how to obtain extension? We flex. In this case, there was a radial head prosthesis was implanted before, and the patient was stiff with lack of extension. We position a retractor anterior in the anterior room of the elbow. We expose the anterior room of the elbow, and we follow the anterior profile of the humerus in flexion, as you see. And the beauty of working in the lateral decubitus position is also that it's a very natural to have the elbow flexing, because the hand goes down by gravity, and we tend to flex the elbow, so we tend to be protected. So we expose the humerus, and we can obtain extension, performing at the end a true and complete capsulectomy, because of course we can create a plane in between brachialis and the capsule, we have first created a plane between the bone and the capsule, and then we do brachialis and the capsule. And we normally stay proximal. So the way in which to perform a capsulectomy is to perform it proximally, because if we stay close to the humerus, we can remove a stripe of capsule without being worried of injuring either the median nerve that is out of the brachialis, or more at risk, the radial nerve that is in front of the radial head. So the only place where we don't want to go is just in front of the radial head, because that's where the posterior interosseous nerve lays. So if you want to perform a capsulectomy, please go proximal. The more you go proximal at the level of the humerus, and the safer it is. In terms of reestablishing rotations, normally it's a synostosis, and this is a problem. Normally what we do is to stay on the ulna, expose the distal part of the ossification, expose the proximal part of the ossification, and trying to preserve as much as we can the ligament insertion at the supinator crease. So we work proximal and distal with two windows, trying to resect the whole synostosis like we have here. This is what we do. We resect it, and if it's impossible, you have to, at the end, to resect also, to detach the ligament in a proper way and to be able to reattach at the end to recreate stability. This is a classic situation of synostosis, with the final result like the one you were seeing here. And you see the motion is reestablished. Best indication for open approach, of course, this sometimes is an approach we do together with an arthroscopic, opposed or thought to be in contrast with the arthroscopic approach, is the stiff and unstable. So situation in which we have to do all the releases, even at the ligament insertion, because there are a lot of H-holds at the ligament insertion, and being able to reconstruct ligament at the end. So when we approach this kind of elbows, we have to work like in oncology. The resection moment doesn't have to compromise the reconstructive moment of the reconstructive phase of the procedure. So normally we perform all our releases at all costs, and once everything is released, we have to recenter the joint, and at that point to use normally a graft. It can be either an autograft or an allograft, or either an autograft or an allograft to reconstruct ligaments. Normally the easiest way, because it just relies on using two tunnels. One is a transapical tunnel, and the second one is a tunnel that connects the supinator crease with medial insertion on the sublime tubercle of the AMCL. And once we have these two tunnels, we connect them, and we loop around in this box loop technique that was developed the very first time at Mayo by several authors, Sean Driscoll before everyone else. And we reconstruct the ligament in this box loop phase. Of course, this can be also done with these two separate reconstruction, but normally it's easier. And in terms of post-op, when we do releases plus reconstruction, is the ligament reconstruction that drives and defines the post-op phases, because of course we prefer to have an elbow that becomes more stiffer, because we can always do a second release, even arthroscopic or several or some time down the line. It's difficult to deal with an elbow that remains unstable. And this is the way in which we have the graft passing from one side to the other and completing the box loop phase and fixing with, in this case, we use an anchor, but of course you can use also free sutures. What we do in the post-op, normally we use CPM to obtain some gliding of the joint and the nerve. In this case, that was published, there was no superiority of CPM respect to physical therapy. So of course, we have to say that the evidences are limited in favor of using CPM, but more recently has been also described this paper in favor of CPM. Of course, I would not I don't think it's critical, in particular if you don't have CPM machines. In particular, we have to concentrate on the final range of motion, because the final range of motion is the one that was lacking prior to surgery, and we have to reestablish at the end. So splint, again, going back to the slides, we were talking about splinting. Splinting, I think, is fundamental. So again, focusing on terminal degrees and preparing splints, like we are seeing here, thermoplastic splinting, or even casting, depending on the situation you are, in the final range of motion, in particular in extension, because always remember the flexion comes with time, because we want to flex, we want to write to our face, mouth, eating, writing, touching our hair, but extension is very much more difficult to stress. That's why splinting extension is fundamental, because otherwise patient will always try to come back to a more flexible position. Of course, in some situations, sport-specific training is fundamental. Of course, depends where you are working and what's your situation. So again, patient-based post-op is key. Sometimes we can do a physio at distance. We associate some physio with splinting, with some lessons, video lessons, or training, or following up patients at distance. This can be done. If ligaments are preserved, we can go for CPM from the very beginning, or in any case, physio from the very beginning, and splinting for terminal extensions for 60 days post-op. And of course, I do believe a lot in self-exercising of the patient, in particular in flexion. There is no better physio than the patient himself, because they want to go in flexion. And flexion comes with time, even in the following months. Extension have to be stressing from the very beginning. If the elbow is stiff and unstable, that's a more difficult situation, and is the stability and ligament reconstruction that plays a major role here. So we have to put patient, I would suggest to keep the patient in a sling for 3 weeks, and then to gain 30 degrees per week in the second phase. And if the elbow remains stiff, but at least stable at 6 months, we can plan a second stage, a revision stage, for obtaining more extension once the elbow is re-centralized and stabilized. Thank you so much, and this is the end of my presentation.
Great job.